Everybody. It is my great pleasure to welcome you at the second webinar of this educational cycle of webinars organized by the Hellenic Group Sarcomas and Rare Cancers. This webinar has a title, Myxoid soft tissue sarcomas of the extremities, recurrence and oligometastasis. Word experts from different specialties, pathology, surgical oncology, radiation oncology, and surgery, will present their point of view on this very hot subject. So it's my great pleasure to introduce and welcome Dr. John Ivey. Dr. John is Associate Professor at the University of Pittsburgh at the Department of Pathology and Director of the Bone and Soft Tissue Pathology Center of Excellence. My pleasure is doubled since I used to work at the University of Pittsburgh at the Department of Pathology. So, Ivy, I would like to welcome you and let you have the screen and present to us your talk. Thanks a lot for being with us today.
Thank you so much for this kind invitation to present. Let me share my screen.
As you see, adesso mette camera. Adesso mette camera.
I would like to ask all of you to mute your microphones in order not to interrupt the speaker. Is there a problem with the share screening? We don't see your screen. Your microphone is muted.
Unmute?
Your microphone is muted.
Okay.
Okay. Okay.
Okay. So, am I sharing my screen now? Are you seeing the actual screen or the presented?
Yes, it's okay.
Yes, we do.
You're seeing the actual screen, right?
Yes, of course.
I'm just going to move this up over here. Okay. So, I guess good evening, everyone. For me, it's morning. I'm talking to you from the West Coast. So today our topic is myxoid sarcomas. So in terms of myxoid sarcomas, there are various basics to consider with myxoid sarcomas. And this is, of course, a very challenging aspect of soft tissue pathology as a result of considerable morphologic overlap between not only malignant entities, but also benign and malignant entities. IHC is often of limited value, unfortunately, with the exception of very few entities. So with myxoid sarcomas or myxoid tumors, there are a few key morphological features to look out for. So one of them is the vascular pattern. So if you come across something known as curvilinear vascular pattern with well-formed blood vessels, you should be thinking about a myxofibrosarcoma. Conversely, if you hear the word crow's feet or chicken wire pattern or a plexiform vascular pattern, you should be thinking of myxoid liposarcoma. Cytology is key as well when you're dealing with myxoid tumors. So if you're seeing a pleomorphic tumor, you should be thinking along the lines of myxofibrosarcoma, myxoinflammatory fibroblastic sarcoma, among others. Whereas if you see more of a monomorphic uniform morphology, you should be thinking about translocation-associated tumors, including myxoid liposarcoma as well as Evans tumor. So for myxoid tumors, they can be distinct tumor subtypes as well as tumors with myxoid variants. So in addition to myxoid tumors, you should also think about tumors that have myxoid variants like DFSV, synovial sarcoma, as well as solitary fibrous tumors. So myxoid tumors of the soft tissue can be broadly divided into superficial or deep. For the purpose of today's talk, we're going to focus on myxofibrosarcomas, which can occur both in the superficial as well as the deep aspect, as well as myxoid liposarcoma and low-grade fibromyxoid sarcomas. So to start with myxofibrosarcoma, as you know, sarcomas only account for 1 to 2% of all adult tumors. However, within that subgroup, myxofibrosarcoma is somewhat common. So we see roughly 2 to 3 myxofibrosarcomas a week in our practice. Granted, this is somewhat of a large sarcoma center. So the typical history for myxofibrosarcoma is an elderly patient between the 6th to 8th decade of life, and with a large mass involving the subcutaneous tissue of a distal extremity. As I mentioned before, a subset of these tumors can occur in the subcutaneous tissue. So when you think about myxofibrosarcoma, you're looking for a characteristic triad of findings. So you're looking for prominent myxoid stroma, elongated curvilinear blood vessels, and pleomorphic cells. These tumors, as I mentioned before, they lack distinctive immunophenotypes, so they can show some amount of variable expression with SMA and CD34. However, other markers will be negative. And these tumors are associated with a complex karyotype. So in order to diagnose myxofibrosarcoma, sampling and careful histological examination is key, and ancillary studies are performed to exclude mimics. So these include studies such as MDM2 FISH studies to exclude the possibility of a dedifferentiated liposarcoma. If you see something that looks like a myxofibrosarcoma in the retroperitoneum, most likely you're dealing with a dedifferentiated liposarcoma, so please always perform MDM2 FISH studies. It's vanishingly rare in the retroperitoneum location. These tumors are graded as low, intermediate, or high, and these are characterized by local, often repeated recurrences, which is unrelated to the histologic grade. Conversely, metastatic risk increases with grade, so high-grade tumors are associated with roughly 20 to 35% chance of metastatic risk, and the epithelioid subtype having a significantly higher metastatic risk of greater than 50%, versus essentially no metastatic risk for tumors that are graded properly as low-grade tumors. So as the common saying goes, what the mind does not see, what the mind does not know, the eyes will not see. So for myxoid tumors, you have to know to look for the vascular pattern. So even at this low power view, we can start appreciating the vascular pattern. And this myxoid fibrosarcoma, by definition, is a pleomorphic sarcoma. So in addition to these atypical spindle cells, you should be able to see pleomorphic cells even at a low power view. And of course, you have the prominent myxoid background. Here again, we can appreciate the characteristic triad of findings, including the nice medium-sized curvilinear blood vessels, as well as the scattered pleomorphic cells and the prominent or abundant myxoid stroma. Another case showing similar triad of findings. So with myxofibrosarcoma, as well as any other myxoid sarcomas, you can frequently encounter what is known as pseudolipoblasts. And these are mimics of lipoblasts. So if people see this and they're not very familiar with pseudolipoblasts, they have a tendency to try and overcall this as a pleomorphic liposarcoma or a dedifferentiated liposarcoma. So these pseudolipoblasts are basically tumor cells that engulfs the stromal mucin. So the vacuoles are actually formed with the mucin. So the coloration of these vacuoles will be very similar to that seen at the periphery or in the stroma, versus a true lipoblast or pleomorphic lipoblast, which has optically clear vacuoles. And this is because they essentially contain lipid, which is washed out during processing. These vacuoles are also much more well-defined in true lipoblasts, and they're often very rigid. So this is an example of intermediate grade myxofibrosarcoma. So we can see how the cellularity has increased. There's more cytologic atypia. There's often increased mitotic activity and often some small degree of necrosis. Versus this is an example of a high-grade myxofibrosarcoma, which is essentially indistinguishable from an undifferentiated pleomorphic sarcoma. And diagnosing this as a myxofibrosarcoma is basically sampling appropriately and finding areas that show the classic triad of findings. When it comes to the differential diagnosis of myxofibrosarcoma, these are basically based on the grade of myxofibrosarcoma. So if you're dealing with a low-grade myxofibrosarcoma, your differentials will include benign mimics, which will be an intramuscular or a cellular myxoma. However, these should not be characterized by, these will not show any pleomorphic or atypical cells, typically very bland as well. And they're also hypo or polyvascular, so you don't see much of a vascular proliferation in myxomas. Myxoid peripheral nerve sheath tumors can also come into the differential. Of course, these can be separated by immunohistochemistry. So S100 will be positive in myxoid examples of neurofibroma. Another entity to consider is the low-grade sarcomas, such as low-grade fibromyxoid sarcomas. These, as we'll discuss later, are translocation associated and will be diffusely positive for MUC4 staining. And of course, in these cases, in low-grade fibromyxoid sarcoma, you should not expect to see any pleomorphic cells. Now, the high-grade spectrum of myxofibrosarcoma should be separated from other high-grade pleomorphic sarcomas, and these include undifferentiated pleomorphic sarcomas, pleomorphic liposarcoma, as well as dedifferentiated liposarcoma. You also have to consider other entities outside the sarcoma group, like dedifferentiated melanomas, among others. So this is a nice example of a myxofibrosarcoma mimic. So it essentially shows you the triad of findings that I told you to look for when you see a myxofibrosarcoma, including the nice curvilinear blood vessels, the myxoid background, and some scattered pleomorphic cells. However, this tumor has two different components. So in addition to areas that look like myxofibrosarcoma, you're seeing a lipogenic component as well. So closer examination shows these are true lipoblasts. They're optically clear vacuole that indents a hyperchromatic nuclei. So this is a lipogenic sarcoma. This is another field which is showing these nice pleomorphic lipoblasts. So MDM2 FISH studies were performed. They were negative. So therefore, this was diagnosed as a pleomorphic liposarcoma. So we did a large study and we looked at a series of 120 cases of pleomorphic liposarcomas, and we found out that myxofibrosarcoma-like morphology is actually seen in over 50% of cases of pleomorphic liposarcomas. Another thing to consider and keep in mind, especially when you're diagnosing epithelioid myxofibrosarcoma, especially in atypical sites like head and neck locations or sun-damaged locations, axilla, groin, is to consider the possibility of the dedifferentiated melanoma as well as the sarcomatoid carcinoma. So we found out that rare subsets of cases that were previously diagnosed as epithelioid myxofibrosarcoma actually harbored NRAS mutations and a high tumor burden, mutation burden, suggesting that these may actually represent transdifferentiated melanoma or sarcomatoid carcinoma. Similarly, if you see a case in the head and neck region and it shows BRAF mutation, always consider the possibility of a dedifferentiated melanoma. So myxofibrosarcoma, as the surgeons will agree, is not a surgeon's friend. And this is because grossly they look very well circumscribed, but there's often extensive microscopic extension. So these tumors often extend to the margin. So this is a gross examination of a myxofibrosarcoma specimen, and granted it doesn't have much of a peripheral rim of normal tissue, it still looks like it's removed in its entirety. However, microscopically, you can see that it has an infiltrative growth pattern, and it seems much more than what you can see. This is the infiltration of the tumor, and it sort of separates out striated skeletal muscle, and it extends into the inked blue margin. Moving on to myxoid liposarcoma, this is a tumor of adults. The peak incidence is between the 4th and 5th decade of life. These are deep-seated tumors, a lobulated growth pattern with abundant myxoid stroma with delicate branching of plexiform capillary network. So when you hear the words or the terminology crow's feet or chicken wire pattern, always think about the possibility of a myxoid liposarcoma. The tumor cells are uniform with a spindle to ovoid nuclei and may show increased cellularity at the periphery and around blood vessels. You can see small univacculated and bivacculated lipoblasts, but these are not required for the diagnosis. So there is a false understanding that lipoblasts are required for the diagnosis of liposarcoma. So this is not the case, with the exception of a pleomorphic liposarcoma. So in terms of grading myxoid liposarcoma, it's graded based on cellularity. We use the two-tier system, which looks at hypercellularity with a cutoff of 5%. So if it's less than 5%, it's considered low grade, and high grade tumors are considered having greater than 5% hypercellular or round cell component. And this is associated with poor prognosis. So high-grade myxoid liposarcomas will mimic round cell sarcomas with solid growth pattern that obscures the characteristic morphology that you expect to see in myxoid liposarcoma. So these tumors are characterized, or they harbor FUS-DDIT3 fusion and rarely EWSR1 DDIT3 fusion. So confirmation is based on FISH studies for DDIT3 gene rearrangement. DDIT3 immunohistochemistry is also available and validated and highly sensitive and specific and can be used as a reliable surrogate. In terms of behavior, these typically have a local recurrence rate of 12 to 15% of cases, and the distant metastasis develops in 30 to 60%, often years after presentation. These tumors are characterized by metastasis to unusual sites, such as soft tissue as well as bone, particularly the spine. And high-grade tumors, as mentioned previously, are associated with a significantly worse prognosis. So this is a low-power view of myxoid liposarcoma, and we can see the characteristic plexiform vascular pattern. We can see the monomorphic cells, spindle to ovoid cells, and prominent myxoid background. And in addition to that, we can see what is known as mucin pooling or pulmonary edema type pattern. So I'd like to focus on this pulmonary edema-like pattern for a minute, because oftentimes this is the morphology that predominates. So on a corneal biopsy, this might be all that you see. So you should be able to associate the pulmonary edema-like pattern to myxoid liposarcoma and do the appropriate FISH testing for diagnosis confirmation. This is a case of a high-grade myxoid liposarcoma. And here we can see increased cellularity, some nuclear irregularities, overlapping of the nuclei, and sort of obscuring of the underlying myxoid architecture as well as the vascular pattern. Another example of a high-grade myxoid liposarcoma showing cording as well as the trabecular growth pattern. And this is an example of a pure high-grade myxoid liposarcoma, which is indistinguishable from a round cell sarcoma, and therefore molecular testing is required to make this diagnosis. So myxoid liposarcomas, as you know, are extremely radiosensitive, and most of the cases that we receive status post radiation will show near complete therapy response. And this is characterized by hyalinized area as well as maturation into white adipose tissue. Here's another example showing dense hyalinization as well as maturation into white fat. So very quickly, one of the great mimics for myxoid liposarcoma is the angiofibroma of soft tissue. This is a relatively recent entity described by Marino Enrique as well as Chris Fletcher in 2012. It's a rare mesenchymal neoplasm that is characterized by fibroblastic as well as vascular components. It's a benign tumor involving the extremities, typically deep-seated, characterized by bland spindle cells, collagenous or myxoid stroma, and a prominent vascular proliferation. These tumors are often misdiagnosed for low-grade sarcomas, including myxoid liposarcomas. They show variable expression with EMA, CD4, SMA, as well as Desmond. This is also a translocation-associated tumor, and most of the cases reported harbor AHRR NCOA2 gene fusion. So moving on quickly to low-grade fibromyxoid sarcoma. This is a sarcoma of the young and middle-aged adults, typically involving patients in their 3rd to 5th decade. They're usually deep-seated, occasionally subcutaneous, particularly in the pediatric age group. In decreasing frequency, they involve the extremities, the trunk, as well as the retroperitoneum. Immunohistochemistry is particularly important in this subset of tumors because majority, over 99%, will show MUC4 expression. So this is a fairly sensitive and specific marker for low-grade fibromyxoid sarcoma, with the exception of really 2 entities, which is it can also stain a subset of synovial sarcomas as well as ossifying fibromyxoid tumors. These tumors, a subset of them can also co-express EMA as well as SMA expression. These tumors are characterized by FUS-CREB3L2 or more rarely FUS-CREB3L1 gene fusions, and rare examples may harbor EWSR1 as opposed to FUS. These tumors are characterized by a low rate of local recurrences and metastasis in the first 5 years after excision of the primary tumor. However, the metastatic risk after 20 years is greater than 40%. So this is a low power view of an example of an Evans tumor or low-grade fibromyxoid sarcoma. So even at low power, you can appreciate the myxoid and fibrous areas. So these tumors are typically more fibrous than myxoid, hence the terminology low-grade fibromyxoid sarcoma. And they're often mistaken for benign tumors in that they have very bland cytomorphology. So these are composed of sort of slender, thin spindle cells, often with a wavy nuclei. So a lot of times these are mistaken for peripheral nerve sheath tumors. This is another example showing the alternating fibrous and myxoid areas. And again, appreciate the very bland cytomorphology. In the more myxoid areas, the cells may assume a more of a stellate architecture or morphology. So they look a little more prominent and the vascular pattern is more pronounced. So it could mimic a low-grade myxofibrosarcoma. However, there should not be any pleomorphism in cases of low-grade fibromyxoid sarcomas. And of course, MUC4 would be diagnostic. This is a recent case of Evans tumor that I had on our bench. This is very interesting because it's a variant of low-grade fibromyxoid sarcoma, previously known as spindle cell tumors with hyalinizing rosettes, but now known to be a variant of low-grade fibromyxoid sarcomas. And this particular case showed a near complete rim of peripheral ossification and therefore mimicking an ossifying fibromyxoid tumor. Here we can see these giant rosettes that are characterized by a central core of hyalinized collagen surrounded by epithelioid cells in a background of what otherwise looks like a low-grade fibromyxoid sarcoma. And here we can have some hypercellular epithelioid areas, which are essentially precursors to the giant cell rosettes. And the tumor was diffusely MUC4 positive and showed FUS gene rearrangement. So with that, I think I'm at 20 minutes. And briefly, the differential diagnosis are entities that are typically MUC4 negative. So you consider cellular myxomas, perineuriomas, desmoid fibromatosis, solitary fibrous tumor, as well as myxofibrosarcomas. Again, all these entities are MUC4 negative. So it's a very easy way to rule out the diagnosis of an Evans tumor. So typically on corneal biopsies of what looks like a cellular myxoma, we typically will add a MUC4 stain to make sure we're not missing a low-grade fibromyxoid tumor. So with that, I will pass the talk to the next speaker. I'm on the West Coast, so we're staying at Carmel, and this is Pebble Beach, and this is the lone cypress, which is an iconic tree, and perhaps the most photographed tree in North America. Thank you for your attention.
Thank you so much, John, for the presentation. We'll go with the questions after the whole presentations. And when we finish the set of the presentation, we'll have the opportunity to present us your cases. So, Dr. Kiazoglu, please present our next speaker.
Hello from my side too. I would like to thank you all for being here. It's a great honor that we have today Dr. Herbert Lung. We are leaving the West Coast and we're going to the East, to the other side of the planet. Dr. Lung is a professor of the Department of Clinical Oncology in the Chinese University of Hong Kong. He is very well known about his work and the research that he does in sarcomas. And he's going to discuss the medical oncologist's point of view for this nice and interesting topic of myxoid soft tissue sarcomas of the extremities. So, Herbert, please, the screen is yours.
Sure, thanks, Tassos, and it's a pleasure to be joining all of you. And actually, you're going a bit more west from the West Coast. You're crossing the Pacific over to now the East, and it's a pleasure to be here. I'm glad I made it on time, as there was some transitioning error and the time zone differences on my Outlook, but I'm glad I'm here on time. So anyways, let me try to share my screen first. Okay, and I'll change it to full screen. All right, so I think you should be able to see the full screen and the slides. So again, thank you, Tassos, for an invitation. It's a pleasure to be able to join all of you. I'm Dr. Herbert Leung. I'm a medical oncologist based in Hong Kong, and my interests are in sarcomas as well as lung cancer. And I've been tasked to talk about the medical oncologist aspects of myxoid soft tissue sarcomas of the extremities. I think the title of today's webinar is really on recurrences and oligometastases. And these are my disclosures. And I think to begin with, I would not pretend to be an expert of pathology. Certainly, Dr. John gave a very good overview of the different pathological aspects of these myxoid neoplasms. From a relatively simplistic point of view, I think in a way, these myxoid soft tissue neoplasms can typically be classified as the benign versions as well as the malignant ones. Certainly each of them have very different pathophysiology, and it's listed in the table here. I think it's suffice to say that the diseases that I normally deal with would be the ones on the right, which are the ones of the malignant pathologies, including, say, myxoid cell liposarcoma, extraskeletal myxoid chondrosarcoma, and others. I think one very important note is the fact that these benign myxoid soft tissue neoplasms, it's somewhat of a misnomer, because although they are benign in the sense that they do not tend to metastasize, they can be still very sinister and locally aggressive. So these are, of course, diseases that I think our surgeons typically may have to deal with as well. Now, again, not pretending to be a pathologist or knowing my molecular pathology well enough, but it's also suffice to say that within the soft tissue sarcoma groups, there are distinctive chromosomal alterations in the different tumor types. And the prevalence of these alterations are also different based on the different histologies. We know, for example, in myxoid round cell liposarcomas, the DDIT3 alterations, the prevalence is up to about 90% for FUS DDIT3, as well as EWSR1 DDIT3 being less than 5%. And the extraskeletal myxoid chondrosarcomas have also their typical NR4A3 fusions as well. Now, this is a summary that I also found in a paper from some while ago. This was actually a paper for radiologists, but I think it gives a pretty good summary in terms of what these tumors may look like in imaging and their natural history and behaviors, as well as some of the molecular alterations. It summarizes it quite well within this particular table. I think as a medical oncologist, though, out of all these different types of histologies, my role really is in two of these, which of course includes myxoid liposarcoma, which again, Dr. John has already covered the pathology of, and then also the other pathology which may be of interest or at least of relevance to the medical oncologist would be extraskeletal myxoid chondrosarcoma. So in the remaining time of my talk, I'll be talking mainly on these two particular histologies. So let's go on to myxoid round cell liposarcomas first. It accounts for about 30% of liposarcomas, and the distinct clinical, pathological, as well as molecular presentation. Typically, it's in the younger age group as opposed to your well-diff, D-diff liposarcomas. We're talking about 30 to 50 years of age, predominance of males over females, and most of the primary lesions are in the extremities, and typically in the proximal extremities. I think the main clinical characteristic of it being different from the well-diff, D-diff liposarcoma has to do with the fact that it has a very different metastatic pattern. It tends to involve fat-bearing areas, including the bones, retroperitoneum, as well as subcutaneous masses, and this is typically not seen in the well-diff, D-diff liposarcomas. Out of all the liposarcomas, why is this particularly relevant to the medical oncologist is because it is the most chemosensitive subtype of liposarcomas, and also in terms of response rates to anthracycline-based chemotherapy, it's been quoted at about 40%, and also in the advanced setting, trabectedin, it's been quoted at about 20%. So a relatively sensitive tumor to various types of cytotoxics. Now, this is a good sort of diagram as well as flow chart, which was recently published by the MD Anderson Group, which was a review article looking at myxoid round cell liposarcomas. And essentially, what you can see is their suggestion for initial workup. and then subsequently what to do in the situation of localized disease, as well as what obviously suggested methods of treatment for patients with metastatic disease. Now, of course, in the initial workup, we would expect the need to do the imaging for full staging, including CT or MRI contrast of the affected area. We, of course, want to make sure that there are no lung metastases or other regions of metastases. And a biopsy, of course, is essential, and denoting the grade of the lesion, as well as the presence or absence of round cell component, which certainly has a prognostic value in terms of the treatment outcomes. And in the situations of localized disease, this is an algorithm that suggested some different places may follow different paths, but essentially for smaller lesions, a wide local excision would be the mode of choice of treatment. And in situations where you have an R1 or R2 resection, you may need a re-resection or also consider external beam radiation in a situation of high-grade disease. Now, I think the important point would be in situations where there is a relatively higher round cell component, and it's typically denoted as greater than 5%, and also in a large size tumor, you would consider doing some preoperative treatments, including external beam radiation, as well as the possible use of preoperative chemotherapy. Now, I think whether or not preoperative chemotherapy is indicated for myxoid round cell liposarcoma is controversial, given the fact that it is actually very sensitive to preoperative radiation. And there are some centers which would consider preoperative chemotherapy not necessarily indicated for this particular type of histology. Having said that, we also have data to support its potential improvement in survival in patients who are given preoperative chemotherapy. So I think it really depends on your center's practice. Now, I think in the situation of metastatic disease, it's quite clear that in terms of treatment, we can consider our treatment approach similar to other soft tissue, high-grade soft tissue sarcomas, including anthracycline-based chemotherapy. Preferably, it would be a doublet chemotherapy of doxorubicin and ifosfamide. Trabectedin seems to be a relatively active drug in this particular disease. So certainly trabectedin would be considered a good second line or later line systemic therapy, or in situations where anthracycline-based chemotherapy is contraindicated, trabectedin can be potentially used as a first-line therapy. There are other agents which are approved for the use of soft tissue sarcomas in general, with some particular predominance of activity in myxoid round cell liposarcomas, and I will go into a little more detail a little later during my talk. Now, going back to the issue of potentially operable patients and in the situation of neoadjuvant chemotherapy, you would recall that this is the seminal paper that was published by Granchi and colleagues, essentially the ISG STS 1001 study, which actually looks at neoadjuvant chemotherapy in a variety of histologies of high-grade soft tissue sarcomas. And the main approach or the main emphasis of this particular paper is to see whether or not a histology-driven chemotherapy regimen is necessarily better than the standard anthracycline plus ifosfamide approach. And patients who have high-grade, deeply seated, more than 5 centimeters in size tumors were randomized to either receive these histology-tailored chemotherapy. And as you can see here, the different types of chemotherapy are based on prior experiences on the different histologies. And in situations of patients with myxoid round cell liposarcoma, trabectedin was the drug that was being investigated, pitched against essentially a anthracycline-based chemotherapy together with ifosfamide, both for 3 cycles, and then followed by surgery, plus or minus the use of postoperative radiation. And you would also recall the fact that this particular study was deemed considered negative in the sense that it seemed as though patients who were treated with standard chemotherapy actually had better outcomes than taking a histotype tailored chemotherapy approach. On the left-hand side is the disease-free survival in the original paper that was published in Lancet Oncology in 2017, where it was quite clear that the patients who were treated with, again, anthracycline-based chemotherapy plus ifosfamide had better disease-free survival as well as overall survival. But specifically, if you look at the different histologies that were included in this particular clinical trial, high-grade myxoid liposarcoma, again, it was pitched against trabectedin, but you could see the effect of the histotype tailored therapy, which would be trabectedin in this case, was more prominent than, say, the other histotype selected chemotherapies in other histologies, which has led to further analysis looking at whether or not, specifically in high-grade myxoid liposarcoma, the efficacy of trabectedin may be as good as ifosfamide plus adriamycin. So more recently, this larger clinical trial has its updated final results published in JCO, and this was actually just published, I think, earlier this year, actually. And looking at the data, just to reconfirm the fact that after a longer period, we are still seeing the fact that patients who were treated with standard chemotherapy did have better overall survival than patients who were treated with the histotype tailored approach. But at the same time, because of the initial analysis showing the fact that myxoid liposarcomas seem to have good efficacy with the use of trabectedin, this particular cohort was further expanded. And the results of this expanded cohort of 101 patients of myxoid liposarcomas were actually also recently published in JCO. And at a 60-month median follow-up, in actual fact, it was shown that the use of trabectedin was non-inferior to the use of doxorubicin and ifosfamide. And if you look specifically at the data of high-grade myxoid liposarcomas in this 101 patient cohort with the use of neoadjuvant trabectedin, on the left here is the disease-free survival probability, with the standard approach being the one in blue, and the tailored approach, which is trabectedin, the one in red. And if you look at the overall survival, which is highlighted by the Kaplan-Meier curve on the right, essentially showing the fact that there is no difference between the standard and the tailored, both for disease-free survival and for overall survival. These lines are intertwined. And I think the take-home message really is the fact that it shows that trabectedin is just as good as standard chemotherapy in this particular histology, and also specifically in the patients who were recruited into these two arms. In actual fact, it was quite clear that patients who were randomized to trabectedin had lower hematological toxicity. There was obviously no hair loss with the use of trabectedin as opposed to adriamycin plus ifosfamide, and also trabectedin also avoids the issue of long-term cardiac toxicity. So at least based on the author's suggestion, trabectedin can be used as a neoadjuvant treatment in patients with high-grade myxoid liposarcoma, and it fares just as good as doxorubicin plus ifosfamide. So aside from trabectedin and of course our standard chemotherapy, which is ifosfamide and doxorubicin, what are some of the other active agents for myxoid liposarcoma? Well, eribulin certainly is an approved drug by the US FDA as well as the EMA for liposarcomas in general. And if you remember the original trial which has led to its approval, there were patients with myxoid liposarcomas who also benefited from treatment, so that definitely would be a good choice. There are, of course, other agents that we tend to use in liposarcomas or sarcomas in general. For example, gemcitabine, typically given on a fixed dose rate fashion, is commonly used. But in actual fact, if you look at the actual data or the evidence, actually the data is relatively scarce, but it is commonly used single agent or in combination with docetaxel, and certainly the side effect profile is quite well accepted. At the same time, another drug of choice may be pazopanib. Now, of course, there is a lot of caution with the use of pazopanib in liposarcoma because in actual fact, this was not, there were no liposarcomas patients specifically in the Palette trial, which led to pazopanib's subsequent approval. But in actual fact, a dedicated phase 2 trial that was also run out of the US from multiple sites actually looked at the use of pazopanib at its full dose, 800 milligrams per day, in advanced or intermediate high-grade liposarcomas, which also included patients with myxoid round cell liposarcoma, and that was 12 out of the 41 patients. And in actual fact, there was some evidence of disease response to treatment, as well as a 12 weeks progression-free survival rate of 66.7%. So I think pazopanib is also an active drug in myxoid round cell liposarcoma. Whether or not you can access this drug because it may not have the label for liposarcoma in your jurisdiction remains a question, but in terms of activity, it's definitely a drug that can be considered, at least in the advanced setting. Now, aside from the standard chemotherapy, there are some novel agents that's being investigated for myxoid liposarcoma. One of the hot approaches is to consider using adoptive T-cell therapy, and there are at least, to my knowledge, 2 international trials that's ongoing or have just completed with the use of adoptive T-cell therapy in the treatment of myxoid or round cell liposarcoma, and these are highlighted in the table on the right-hand side. Of course, this is either to target NY-ESO-1 or the MAGE A4. The MAGE A4 compound, or the Spearhead clinical trial, has also recently just been published in Lancet Oncology. And specifically, the Spearhead 1 results, as I mentioned previously, was published. The primary author, or the principal author, was Dr. Sandra D'Angelo. In actual fact, in this particular clinical trial, they looked at both synovial sarcomas as well as myxoid round cell liposarcomas, which both commonly do express the MAGE A4 antigen. And the results here are on the right-hand side, which actually shows the overall survival curve. And in the patients who actually responded well to treatment, they had a good overall survival. And the patients who did not respond did not have good overall survival. But specifically, actually, if you look at the responses, as I've mentioned previously, most of the patients were actually synovial sarcoma patients. Out of the entire patient population, there were 8 patients with myxoid round cell liposarcomas, and these are denoted by the bars with the asterisks or the star. And what you can see is we do have some responders in patients who have myxoid round cell liposarcoma, and certainly this is a promising approach for patients with this particular disease, at least in the advanced setting. Now, just to move on very quickly to the other histology, which probably has some role for the medical oncologist, and certainly that's extraskeletal myxoid chondrosarcoma, or EMC. This is an ultra-rare mesenchymal neoplasm affecting less than 1 per 1 million population, typically presenting in adults. The median onset is in the 5th decade of life. Typically, it presents in the deep soft tissue of proximal extremities, as well as limb girdles, and the thigh being the most common site of the primary disease. It can also, of course, occur in other sites as well, really varying from the trunk to the head and neck region, paraspinal soft tissue, within the abdomen, retroperitoneal space, or bone. And it's also a misnomer because in actual fact, although it's called extraskeletal myxoid chondrosarcoma, there is actually no cartinaginous differentiation within the histology itself. But for historical reasons, I think the name has been kept to continue for identification purposes. I'm not going to pretend to be a pathologist here, but essentially you can see the histopathology on the panel A here, as well as the fish. And what you can really summarize in terms of its behavior or activity to treatment is typically it is responsive to VEGF inhibitors. And a case vignette is attached here on the right-hand side of a patient who was treated with sunitinib. In actual fact, there was some resolution of the intraperitoneal metastases. The patient was treated for about 2 years of treatment and decided to stop treatment. And after stopping treatment for a couple of months, the lesions came back. The patient was resumed on sunitinib, and there was disappearance in the lesion again. And I think it doesn't necessarily have to be sunitinib. I think it tends to respond to other VEGF inhibitors as well. It is relatively chemo-resistant though, but it may respond to radiotherapy. So there may be a role in situations where if there are oligoprogression, for example, the potential use of radiation therapy to try to treat those more active lesions can be considered as well. So, in summary, essentially, myxoid sarcomas encompasses a broad range of histologies with very differing biologic behaviors and response to systemic therapies. I think what's very important is we need to appropriately identify the specific histology because they behave very differently, and we need, of course, very good pathologists to be able to clearly identify these histologies, so we would then be able to plan the treatments accordingly. Multidisciplinary approach is essential. There will be roles for surgery, there'll be roles for radiation as well as systemic treatment. And certainly from a medical oncologist point of view, we do look forward to some of the novel therapeutic ideas, including novel immunotherapies, especially in the myxoid round cell liposarcoma. So do watch this space, and hopefully we'll have some more data readout in upcoming meetings. So with this, I'd just like to end just a quick plug in the sense that we have just held our sarcoma masterclass earlier this weekend, and we were able to invite Professor Rick Haas from the Netherlands to come join us. And we will continue to host this masterclass next year as well. And there's definitely going to be a virtual hybrid component. So we do look forward to welcoming our friends from Greece to join us if the time difference allows. And hopefully we'll be able to have some more discussions then as well. So with this, I think I'll end, and happy to answer some more questions during the panel discussion at the end. Thank you.
Thank you very much, Herbert, for this nice overview. I think we should continue, and then we will be back with comments, questions, and maybe discussion of cases. So the next will be presented by Dr. Mem. I think he's the surgeon, or not.
I will welcome Panagiotis.
Yes, yeah.
Dr. Gikas is the next presenter, and he's going to teach us on the surgical management of soft tissue sarcomas of the extremities. Dr. Gikas is a consultant orthopedic and sarcoma surgeon at Cleveland Clinic of London, and also a visiting professor of orthopedic surgery at the University of Cyprus. And through the last years, he also made a comeback to our country as a surgeon of sarcomas at the Athens Medical Center. Dr. Gikas, it's a great pleasure having you with us among the other speakers, and it's also a pleasure that we have you as a member in the Hellenic group of sarcoma and rare cancers. The microphone is yours.
Thank you very much, Professor Agorgiannis. It's my turn to thank the organizing committee, Professors Papachristou, Kyriazoglu, Agorgiannis, and Memos for this kind invitation. I'm talking to you now from what you can see from my window from sunny Notting Hill in London, and I will be taking a plane in a couple of hours' time to come to Athens later tonight. So I have to say I work between 3 different countries, and only in Greece I've been lucky to see such high quality webinars, and my congratulations to the organizing committee of the Hellenic Sarcoma Group. So it's, I always feel inadequate when I have to follow my presentation after an histopathologist and an oncologist. There's so much that a surgeon can say about management of complex and rare tumors, apart from simply taking it out when I'm asked to. But I will start my presentation by giving you 2 relatively recent examples of the 2 main types, in my view, of myxoid soft tissue sarcomas. And in fact, we are going to, they're going to be similar with the ones that Professor Lung have just presented. And then I'm going to concentrate a little bit on the title of the webinar, which is the basically oligometastatic disease, and give you some of my thoughts on the management of oligometastatic disease with these soft tissue sarcomas. So, first of all, myxoid liposarcoma, we've already heard from the presentation before. It is the 2nd most common type of liposarcoma, followed basically the conventional.
Panagiotis, we don't see your screen.
Oh, you cannot see my screen. Okay, let me see why.
Just share the screen with us.
I thought I was doing that. Let me see, share screen.
It's okay now.
Is it
Okay.
better now?
It's
Yeah.
okay.
Yeah, so there you are. My apologies. So as I was saying before, I'm going to speak about the two very common, of the most common subtypes of myxoid soft tissue sarcomas, the similar ones that were presented in the previous presentation. And then I'm going to talk to you a little bit about my thoughts on the management of oligometastatic disease. So a myxoid liposarcoma, this is the second most common type of liposarcoma, following the more conventional types of liposarcoma, such as the atypical lipomatous tumors and the well-differentiated liposarcomas. The majority of these cases occur in the lower extremities. They have the propensity to metastasize to unusual sites before they go to the lungs, such as the axilla, lower limbs, retroperitoneum, and liver, unlike other types of extremity sarcomas, and they can present with oligometastatic disease. Typically on MRI, they have a myxoid component, which tends to be hypointense to muscle on T1 imaging and hyperintense on any fluid-sensitive sequences. And this is an example of a recent case in a 35-year-old young man. We can see here a large tumor in the posterior aspect of the thigh, in close proximity to the femoral vessels anteriorly and the sciatic nerve posteriorly. And you can see this diffuse heterogeneous enhancement with hypointense on T1 imaging, hypointense to the skeletal muscle, and hyperintense to, as I said, to fluid-sensitive sequences. We've been through histology in detail, but this is typically the appearance on the microscope with myxoid areas interspersed with mature adipocytes. This is, in terms of surgical considerations for this case, obviously, as you can appreciate, whenever you have a tumor close to important structures such as neurovascular bundle, and we're talking here about the femoral vessels anteriorly and the sciatic nerve posteriorly, the aim is to use a neoadjuvant treatment that will allow you to sterilize as much as possible the area around the tumor and allow the narrowest possible margin in order to save these vital structures. And this case was treated with neoadjuvant radiotherapy and then surgical excision with a narrow margin, as you can appreciate on both the vascular side and the nerve side. The other example of a very typical myxoid soft tissue sarcoma of the extremities is the extraskeletal myxoid chondrosarcoma. As it was mentioned previously, this is unrelated to the chondrosarcoma of the bone. It is a tumor of uncertain differentiation with no unequivocal evidence of cartilaginous differentiation. So in a lot of ways, as Professor Lung mentioned before, it's a misnomer. It happens typically in the deep soft tissues of the lower extremities. There are no MRI features typical of chondral tumors, and there is no mineralization, as you would expect to see on a typical chondrosarcoma of the bone. And typically on histology, you see cords, ribbons, or nests of small cells embedded within a myxoid matrix. Often it is associated with late local and distant relapse. This is again an example in a 45-year-old lady of an extraskeletal chondrosarcoma around the ankle joint. You can see here the associations of the tumor both on the lateral aspect of the ankle joint as well as the anteroposterior view with close association to the bone, to some extent also infiltrating the bone, but also surrounding tendons and vessels around the ankle joint. And this case sadly had to be treated with a below-knee amputation in order to get an adequate surgical margin. This is typical histology. You can see again the myxoid stroma with cords of cells interspersed within that myxoid stroma. So the topic of this webinar that I was given is oligometastatic disease. And taking an example of these myxoid soft tissue sarcomas, I thought that I will give you some thoughts on my experience with management of oligometastatic disease. In my view, there are two groups of patients that we need to consider when we're talking about oligometastatic disease. On one hand, you have patients presenting de novo with oligometastatic disease. In other words, patients who at presentation have oligometastatic disease. And of course, in these cases, an MDT approach is paramount, is crucial, and you have to consider chemotherapy and then possibly surgery. And then you have another group which behaves slightly different. These are patients who has had the primary tumor addressed and then present with oligometastatic disease in the future. Of course, again, MDT discussion of these cases is crucial, but in those cases, maybe surgery alone may be sufficient in order to deal with the oligometastatic disease rather than having any adjuvant treatment as in addition. And there is no doubt that we know from our experience that there is a patient population where being aggressive and rendering the patient disease-free has potential for long-term benefit, long-term prognosis benefit. The most important factor here is the tumor biology, and the aggressiveness of the tumor is key, as well as is the chemosensitivity of the specific tumor in question. The main goal in the treatment of oligometastatic disease is to gain long-term disease control using a radical treatment that is technically feasible and has acceptable toxicity and morbidity. The technical feasibility here is an important element in the definition of oligometastatic disease and in the definition of the management of oligometastatic disease, due to the fact that radical treatment may not be possible due to the location of the metastatic lesion or the patient's comorbidity. And therefore, whether or not we are able to perform a technically feasible procedure, whether this is chemotherapy, radiotherapy, surgery, radiofrequency ablation, or cryoablation, this is the technical feasibility of the technique, of the therapeutic technique we use, renders is paramount and important in the management of the oligometastatic disease. So in the carefully selected patients with oligometastatic disease, surgery is considered a treatment when the goal is to increase recurrence-free or progression-free survival. Surgery, of course, may also be offered for palliation when it is for symptom control. Simple example, you have a patient with a soft tissue mass in the extremity that may be causing pressure or pain. Then if surgery is technically feasible and associated with low morbidity, then that can be performed for symptom control only. Palliative surgery in metastatic disease is not very well established, and considerations need to be given to potential complications of surgery in a patient in which the operation may and probably doesn't improve overall survival. And we know for experience, and particularly in cases of retroperitoneal sarcomas, that debulking surgery has been shown to cause significant morbidity and mortality with very little benefit. And therefore, debulking benefit in debulking surgery in my armamentarium, in my toolbox, is not an option unless we are talking about very specific cases with very specific anatomy and very specific symptomatology that may palliate the specific patient symptoms. So what do we need to consider when deciding how we are going to deal or manage surgically or in other ways oligometastatic disease? First of all, we need to consider about the tumor biology, the histology, the grade, the aggressiveness, the time from presentation to recurrence, and the location of metastasis and the anatomical considerations. We need to consider the patient's ability to tolerate an operation. Are they fit? Are they frail? Do they have comorbidities? What is their ASA status? We need to consider the overall prognosis. What is the predicted overall survival? What is the primary resection margin status? And what has been the response so far to chemotherapy? And of course, we can never forget the importance of the multidisciplinary tumor team approach, where we need to get input not just by the surgeon, of course, but by the medical oncologist, the radiation oncologist, the histopathologist, and the palliative care team, because we need to carefully assess the risks versus the benefit of all treatment options provided. And finally, and most importantly, we need to speak to the patient. We need to ask the patient what are their expectations and what are the goals of care. Is it symptom management? Is it quality of life? Is it any potential prognostic benefit? So the typical patient has limited disease. So the typical patient that we will consider for surgical management of oligometastatic disease has limited disease, has an acceptable surgical risk. Of course, depending on the pattern of disease and the characteristics of the metastasis on imaging, we may or may not consider repeating a biopsy prior to deciding what treatment we're going to offer. And this is, of course, this is a decision that will be made within the setting of a multidisciplinary team meeting. These are typically patients who have less aggressive histology And typically and classically, there is a longer time between the primary resection and the metastasis presentation. So in terms of conclusions, and I'm going to finish here, and then hopefully we will have some, I have provided some triggers for discussion later on. The management of oligometastatic disease in soft tissue sarcoma remains inconsistent, and there are two main reasons for that. First of all, we're dealing with rare diagnosis and a diversity of histological subtypes. Metastasectomy generally has been reserved for fitter patients with oligometastatic disease due to the elevated risk of such operative procedures. The excess risks associated with radical surgical approaches is probably coupled with superior outcomes across disease sites. In other words, even though we don't have any randomized trials, and even though we cannot be absolutely certain, surgical excision of metastases in the setting of oligometastatic disease offers a superior survival outcome compared to other treatment modalities. And in fact, there is a global dogma of resecting metastases where possible and reserving radiotherapy or radiofrequency ablation for inoperable cases and this is a global dogma which generally is difficult to challenge in the absence of any obvious and objective data. Active surveillance, of course, we cannot forget that active surveillance is a viable alternative option. And prior to committing to any definitive treatment, surveillance may not only allow for a better characterization of metastatic disease, but also assess the patient's fitness for an operation or inquiry or research an alternative local intervention. The rationale of management approach in patients with low volume metastasis and indolent biology, it gives us the opportunity by adopting a more surveillance approach to assess the tempo of the disease, identify the most appropriate strategy for the individual patient, and indeed lead to the selection of any local therapy for oligometastatic relapse that may be most appropriate for the patient, ranging from what we said, our tools being surgery, cryoablation, radiofrequency ablation, radiotherapy. And finally, and I cannot emphasize that enough, and we have all mentioned it so far in our presentations, patient selection and the multidisciplinary discussion and evaluation of oligometastatic disease is crucial in terms of offering the best possible therapeutic approach to the patient and ultimately getting the best possible outcome. Thank you very much.
Thank you very much, Panagiotis, for your nice talk. And as the previous presenters asked for, we will follow with the questions at the end of the whole spectrum of presentations. And it's time to give the microphone to Nikos Minomos.
Hello, everyone. Thank you for accepting our invitation for this webinar. I'm really happy to present Dr. Luisa Vini, who is a consultant radiation oncologist at the Iatriko Medical Center. She was trained at the Royal Marsden Hospital in the UK, and then she stayed there as a consultant for radiation oncology. And Luisa, we're waiting for your talk.
Thank you so much, Nikos, and thank you all for the invitation to take part to this very, very interesting meeting. I think I have a problem with I'm very sorry. I do apologize. I will try to, if you just give me 1 minute.
Yes, of course. Okay. Parto.
Πλήρης οθόνη. Τι θέλετε, παράθυρο, καρτέλα?
I'm really sorry, I do have some problems. I'm trying to solve them.
No worries, no worries, Dr. Vini. As long as you can fix this problem, we can do some questions with the previous speakers, and you can fix your presentation.
Okay.
Is it okay?
Thank you very much.
This is really good. Okay. So, yeah, does anybody would like to start? Because I already have a question.
You can start, Tassos.
Yeah, okay.
And then
I will start with a question mainly for Professor Lung and Dr. Gikas. So, my question to Dr. Lung is, so for at least for myxoid liposarcomas, which is your way of doing things when it comes to neoadjuvant? Do you go with neoadjuvant radiotherapy, or there are some cases that you work with neoadjuvant chemotherapy?
Yeah, that's a good question. And our own practice is to give neoadjuvant chemo and then radiation and then surgery. So, I mean, there's no doubt that neoadjuvant radiation is important for myxoid liposarcoma. And certainly you may be aware of the DO-RE-MI study, which actually looks at a dose reduction in terms of the radiation leading to just as good efficacy. I believe they use 36 gray as their neoadjuvant treatment. But I think, that probably improves local control, most definitely. But I think, in the space of trying to prevent distant metastasis as well as improving overall survival, I think there is still a role for chemotherapy. And also for very practical reasons, chemotherapy can be started quite quickly when the patient first presents, whereas radiation therapy still requires the planning, etc. So our own practice is to use neoadjuvant chemo followed by radiation and then surgery.
And now the question to Dr. Gikas and probably also again you, Herbert. When we have oligometastatic disease, would you like, Dr. Gikas, something to start before your excision, or would you like chemo? Would you like radiotherapy? Would you like to do the excision before, and then we can discuss whether we are going to give something, and which is going to be this something, Dr. Lung? Because I think that you do so also. I try to keep the weapons back. I try to keep doxorubicin for the time that I really need it. So,
I think what we are certainly we are learning with these cases that you can certainly there's no rule or the same thing that fits everyone. Okay, each case is individual. Very broadly speaking, as I mentioned in my presentation, I think that if you have de novo oligometastatic disease, then yes, in these cases, you have to give probably chemotherapy and then consider any surgical excision. If you have a patient who has been reasonably stable and presents with a distant metastasis or oligometastatic disease, then again, obviously discussion in an MDT setting is crucial, but providing this is a approachable and easily resectable lesion with with a good surgical margin, then I would certainly consider going straight into surgery than giving again chemotherapy, radiotherapy. Providing this is that is at a second presentation, not at the initial presentation. But of course, again, if the question mark there is where is the metastatic lesion, and going back to what I said before, how technically feasible addressing the metastatic lesion is, whether it is with surgery, radiotherapy, radiofrequency ablation, etc. So it is the type of presentation, the chronicity of the presentation, as well as the technical feasibility of your management option for the metastatic lesion.
Okay. George, I think you had a question, or am I wrong? Yes, please.
Yes. Thank you all for your nice presentations until now. I would like to make a question to the colleague, Dr. Ivy John. One of the major problems that I'm facing is the differential diagnosis between an intramuscular myxoma and a low-grade myxofibrosarcoma, especially in the context of GNAS negative mutation analysis. I think it happens about at 30%, at 1/3 of myxomas to be negative for GNAS. How do you proceed in small biopsies in this context?
I mean, we always have a disclaimer that sampling bias cannot be excluded in our comments. But typically with the intramuscular myxomas, you're not supposed to see any degree of cytologic atypia or pleomorphism. So it's a very bland appearing lesion, and myxofibrosarcoma by definition is a pleomorphic sarcoma. So by definition, you have to see some pleomorphic cells in order to make that call.
Okay, I mean, because in small biopsy specimens, sometimes, of course, mitotic activity is very difficult to be counted, but also, is it enough, a minimal atypia, some pycnochromatic nuclei or some dark-shaped nuclei is enough to name the tumor as a low-grade?
So I mean, it is a little bit of a challenge in that, particularly in cellular myxomas, you can have some increased cellularity and things like that, and it can overlap with, Evans tumor as well as myxofibrosarcoma. But myxofibrosarcoma, you need to see the atypical cells, and you also see vascularity, those curvilinear vascularity.
Okay.
With myxomas, it's a paucicellular, pausivascular neoplasm. So you're not typically going to see those well-formed curvilinear blood vessels. It's a bit of a subjective call, and it also depends on the familiarity the pathologist has with these entities.
I agree. I pay much attention to the vascularity. I think that this is a key feature that sometimes helps, especially more biopsies. I mean, of course, you have some myxomas that could be have cellularity, but usually you don't see increased cellularity in myxoma. So I think this is a helpful feature, at least for me, to differentiate these cases in case the molecular findings are not helpful. I have a question.
And usually the differential is cellular myxomas and low-grade fibromyxoid sarcomas. A lot of people have difficulty telling those apart, but for those cases, MUC4, IHC, or FISH for FUS is usually helpful and definitive.
Sometimes low-grade myxofibrosarcomas can cause problems.
Some confusion, absolutely.
The myxoid matrix, sometimes they can confuse in small biopsies.
LGFMS is much more easily to be excluded based on the MUC4 marker.
Exactly.
Yes, I mean
just a second. We don't have a special marker for a low-grade myxofibrosarcoma. This is the problem.
That's why I'm telling that this is mostly the problem.
To continue this question to the surgeon, Panagiotis, or maybe Nikos could answer. How serious is the mistake? Let's suppose that a non-specialized pathologist made the mistake to overdiagnose cellular myxoma, intramuscular myxoma as a low-grade myxofibrosarcoma. How serious is this mistake for the surgery?
Well, potentially it can be serious, yes, because an intramuscular benign intramuscular myxoma can basically, you can remove it marginally without removing any, essentially you can take it out of its capsule and that should be sufficient. And therefore, effectively, you're doing an intralesional excision, theoretically, strictly speaking, if you are discussing along surgical oncological principles. A low-grade myxofibrosarcoma, and again, I personally have the tendency to approach myxofibrosarcomas more aggressively, irrespective of the grade, even the low grade ones, precisely because of what was mentioned by our colleague earlier on today, how this can be very surgically challenging. Because of this, I always consider the pseudopodia that extend, and you cannot macroscopically see them on your MRI scan. So in order to be confident that you have a good margin, you have to go further beyond of what you think is the end of the tumor. So effectively, if you overdiagnose it, then at the worst case scenario, you've removed some healthy tissue and that's it. But if you underdiagnose it, then potentially you can end up with a positive margin.
Yeah.
Having said that, okay, you end up with a positive margin and then you go ahead and you redo a re-excision if you get the correct diagnosis. And we know from a lot of studies that if you have a whoops procedure and you go ahead and re-excise the surgical bed, that's not associated with any prognostic disadvantage. In other words, it doesn't change the prognosis of the tumor, providing you ultimately get the right diagnosis and you get a negative margin.
Thank you very much for your answers.
I have a question.
Also, one more quick thing. I just want to say that for cellular myxomas and intramuscular myxomas, the gene as mutations are seen in greater than 90% of cases. So usually it is pretty helpful.
Okay.
I have a question for Dr. Ivy and also for Dr. Gikas and Dr. Memos. It has to do with a capsule. I mean, if you have a low-grade sarcoma that has a capsule, we all know that this capsule is the product of the tumor. It's not something healthy. It's something that is tumorous. So how confident are you just to remove with a capsule and not have more wider margins?
So from our point of view, we always indicate that the tumor is separated by a thin attenuated capsule, and we leave it to the surgeon to decide.
And when you see the capsule, this capsule, you see a malignant cells in this capsule, I mean, you expect to find that it's something that you call it, or you consider this as part of the tumor and not something which is healthy?
So if it has a well-defined capsule that does not contain malignant cells, we will call it negative, but we will indicate in our report that it's separated by a very thin attenuated capsule.
So from a surgical perspective, the capsule is a good guide in terms of it's there to assist you do your operation. Okay. However, if I know for a fact that this is a malignant tumor, I will not be happy with my work if I just stayed at the capsule. Okay. If I know it's a benign tumor with confidence, then I'm happy to just follow the capsule as a surgical guide of what my excision is. But even in a low-grade lesion, providing anatomically I have the ability to do that depending on surrounding structures, I will tend to go further than the capsule.
Okay. And as regards the limit and the margins in a procedure which is quite easy, which you think is a safe margin? I mean, for a low grade and for high grade tumor. I mean, I know we all know.
I think encyclopedias have been written about that question.
Maybe some people the audience not very familiar with the subject would like to know.
I mean, I think obviously our pathologist will tell us her opinion, but I mean, how long is a piece of string really is the answer. In reality, it really depends on the type of your margin. Is it fat? Is it fibrous tissue? Is it membrane? What is the margin? And it really, you're limited by the location and how much healthy tissue and what are the important anatomical considerations of the tumor. So I think as a very rough, very extremely rough principle, I tend to accept. I would be happy with about a 1 centimeter margin in a soft tissue sarcoma, but I'm very cautious whenever I see significantly bigger margins quoted in reports, because I think for an aggressive soft tissue lesion, margin above 2 to 3 centimeter. Really, for me, in my book, that's an amputation. That's not a surgical excision. So you have to be a little bit careful and cautious about how you read these reports.
So
I agree. Our surgeons are also happy with the 1 centimeter margin. And as Dr. Gikas mentioned, sometimes your deep margin is the periosteum. So there's not much further you can go.
I have a question regarding the low-grade fibromyxoid tumors that the sarcomas, although you mentioned it's low-grade, it gives like 40% lifetime risk for metastasis. I think a question for the panel would be, how would you treat a patient with a preoperative biopsy of low-grade fibromyxoid sarcoma? Would you treat it aggressively or neoadjuvant chemo with this data showing that almost 1 in 2 will have a metastasis in the future?
So I'll start, Nico. So for me, if I have a preoperative diagnosis of low grade, or at least for my MDT, I would be very unlikely to favor neoadjuvant treatment for a low grade diagnosis, okay? Whether it is chemotherapy or radiotherapy. So I will go straight to surgical excision, and low grade or not, I will try to give the best possible surgical margin. In other words, providing anatomical considerations allow it, I will give a widest possible margin. And then, if the diagnosis changes at the excision specimen or the grade changes in the excision specimen, then consider any adjuvant treatment.
Nikos, I don't know. I'm not sure if the term low-grade fibromyxoid sarcoma is a misnomer, because despite its indolent appearance, no severe mitotic activity, no severe atypia. As we have seen previously at the nice lecture of Dr. John, they tend to metastasize through the years. So finally, they not, in terms of clinical practice, not in terms of pathology, they are not finally so low grade through the years, because half of them tend to metastasize.
Yeah. Any marker that can give us who will have a metastasis or not? I know it's low grade though. Do you have any molecular marker, or NGS might help on that?
No.
Because
So sometimes you have hybrid. I'm sorry. Sometimes you have hybrid tumors, so you'll have areas that look like Evans tumor or low-grade fibromyxoid sarcomas would coexist with areas that look like SEF or sclerosing epithelial fibrosarcomas. So those tend to do worse prognostically.
Myxoid liposarcoma is a great example of what happens with the grading. Grading is, in most cases, defined exclusively by morphology and not by the modern molecular findings. For example, both low-grade and high-grade myxoid liposarcomas harbor the FUS DDI83 fusion, so they do not define the grade of the tumor. The grading is mostly defined by the appearance of the tumor, the mitotic activity, necrosis, and the differentiation.
As happens with most of the sarcomas, especially the myxoid ones. Grading is a histopathological point of view. So
Okay.
if there are no questions, I mean, maybe we could, if Dr. Vini is not ready, maybe we could proceed with cases. So, I mean, if you all agree, you could proceed with cases.
I think she sent the presentation to Vasiliki. Vasiliki, do you have the presentation?
No, not yet. Not yet, I think so.
Mhm.
So we should, who would like to start with a case presentation? I mean, from the presenters.
I mean, maybe you could follow the route that we had at the beginning.
Okay, good.
To be confused. So, Dr. John, please.
Sure.
Thanks a lot.
One second. Sorry, I'm just going to progress this way. Okay, so I'll start with case 1. Are you able to see my screen?
What happened now, Vasiliki?
Yes.
What happened?
Okay, I will stop share Luisa's presentation and I will leave Evie.
So are Dr. Vince's presentation ready to be presented? So maybe we could proceed with Dr. Vince's presentation and then go to the cases.
Yeah.
Okay. I'm sorry about that.
No problem.
Okay, we could please later just to finish the part with the cases.
Do you want me to share Luisa's presentation?
Yes.
Okay.
Yes.
Hello again. I'm really sorry for all these problems. I hope you are able to see my presentation now. Thank you very much, Nikos, and the whole organizing committee for inviting me. Are you able to see my first presentation?
Yes, we can see it, but it's in the presenters.
All right,
mode.
thank you very much. I organized my talk with two cases of mine. The first one is a 34-year-old female
Okay.
who presented almost 10 years ago with a low-grade.
Okay.
Vasiliki, we need to move to the next slide.
Oh, yes. Can we move to the next slide, please?
Is it okay now? Second case?
Yes. Can you move to the next slide?
It doesn't work.
Wait. Which one do you want?
The second one?
Second page?
Yes.
First case, metastatic myxoid.
First case, yes.
Okay.
Vasiliki, the presentation was correct. You should move to the next slide, not to the next presentation.
Which one? I don't understand.
Share the same presentation again. Please share the same presentation.
Luisa's, you mean?
Yes.
Okay, and now move to the next slide, the slide 2.
Βασιλική μου, το επόμενο slide, όχι να πας στο επόμενο.
Δεύτερη διαφάνεια.
Δεν έχω
δεύτερη
κάτι
διαφάνεια.
άλλο. Αυτό έχω.
Βάλ' το στην παρουσίαση. Στην παρουσίαση. Ναι. Αυτό. Ωραία, και το επόμενο και το επόμενο. Βάλ' το στο παρουσίαση. Μπράβο. Κάτω δεξιά, μα πας στο ποτηράκι. Το ποτηράκι κάτω δεξιά, εκεί, πάρα δίπλα. Δίπλα από τα σχόλια. Πάρα δίπλα.
Δίπλα στο πλήν.
Δεν το καταλαβαίνω τι μου λέτε.
Ένα λεπτό, ρε παιδιά, ένα λεπτό. Συγγνώμη, να πω λίγο, Βασιλική, άκουσέ με λίγο. Πήγαινε πάνω αριστερά, πήγαινε προβολή παρουσίαση όπως είσαι, αποτρέχουσα διαφάνεια. Αριστερά, αποτρέχουσα διαφάνεια.
Okay. Εδώ.
Το πάτησες από τρέχουσα
Το
διαφάνεια.
πάτησα, ναι. Εγώ το βλέπω, την κίνηση.
Σε εμάς έχει μείνει το ίδιο. Εγώ βλέπω το ίδιο.
Το ίδιο. Ωραία, κάτσε ξανά.
Δεν πειράζει, δεν πειράζει. Δεν πειράζει. Άφησε το όπως ήταν να το συνεχίσουμε.
Άφησε το όπως είναι. Σωστά.
Okay. Sorry for this interruption. We can continue with the presentation of Mrs. Dr. Vini this way. No worries. No
Could
worries.
you go back 2 slides, please? This is the okay, the second one. Okay.
Τώρα φαίνεται.
Ναι. So my first case is a 34-year-old lady who presented almost 10 years ago with a low-grade myxoid liposarcoma of the right gluteal area, and she was treated with surgery and radiotherapy. She remained well for 4 years, and then she presented in 2018 with pain in her left buttock. She was found to have a lytic metastasis in the left iliac bone, which was confirmed histologically, and she was treated with 3D conformal radiotherapy, 40 gray in 15 fractions. She had a very good palliative effect, and she was well for almost a year when she came back again complaining of low back pain. All investigations revealed another lytic metastasis in the body of L5 vertebra, and at that time, that was the only site of disease. She had a lot of pain, and she was treated with SBRT, stereotactic body radiotherapy, 35 gray in 5 fractions. Again, she had a great pain relief. 2 years later, she presented again with pain in her left buttock and upper thigh, and she was found to have a metastasis in the left acetabulum. That was also treated with SBRT, 30 gray in 5 fractions. The following slide, please. Could you move on 1 slide? The previous one? Fine. The previous slides, please. Yes. Last year, she had abdominal distension and discomfort, and she was found to have a mass between her stomach, liver, pancreas, which was slowly growing, and at the end of last year, her MRI showed a large multilobulated, almost 20 centimeters in maximum diameter intra-abdominal mass, which caused her a lot of pain at the time. She had also a small mass in the pelvis, but no other evidence of disease. She was treated with VMAT radiotherapy, 35 gray in 50 fractions, and again, she had a good pain relief. About 6 months later, at the beginning of this year, the pelvic mass increased in size significantly, measuring approximately 12 centimeters and causing her a lot of discomfort. Again, she was treated with radiotherapy, the same dose, and had a quite good pain relief. The following slide, please. At her reassessment with full body MRI a few weeks ago, all her disease in bones remained stable, basically non-active. she had a significant response. The previous slide, please. She had a significant response, as you can see on the lower left side in the large intra-abdominal mass. And she had also a significant response in the pelvic mass. I should mention that during all these years, almost a decade, the patient had also disease in her left breast, which was managed surgically, right kidney, and several subcutaneous nodules. She is now progressing again in the abdomen and is currently under systemic. The following, please. My second case is a 68-year-old male who presented in 2019 with a large grade 2 myxoid fibrosarcoma of the left arm, and he was treated with surgery and adjuvant radiotherapy. The patient was a highly educated physicist and also schizophrenic, refusing any systemic treatment and mainly having lots of problems in dealing with his disease. 9 months after his initial presentation, he was found to have a solitary metastasis in the lung, which was removed surgically. And only a couple of months later, he had a new lung lesion close to the previous one, which was excised, but this time that was treated with SBRT 50 gray in 5 fractions. And on reassessment, only a few weeks later, he had a good response. The following one, please. Soon after that recurrence, he developed severe pain on the upper part of his body and was found to have a metastasis in the left upper rib and also in a 7th thoracic vertebra, and again was treated with radiotherapy. During all this period, he refused to have any systemic treatment. A month later, he developed 2 other lung metastases and again asked for more treatment, radiotherapy again, which was given to him. But soon after that, he developed serious symptoms, pain all over his body, abdomen, and was found to have progression with multiple metastases in lungs, bones, peritoneum, and all of the treated areas. He died of disease in March of 2021. The following one, please. Within this very heterogeneous group of diseases, like the sarcomas, we have extreme differences in their sensitivity to radiotherapy. As we have seen in the first case of the young lady with a myxoid liposarcoma, her disease was very, very sensitive to radiotherapy. From reported cases and small series, we now know that myxoid liposarcoma is one of the most sensitive to radiotherapy sarcoma. The mechanisms underlying this radiosensitivity are not known. It could be due to damage to the rich capillary vascular network, or it might be due to induction of differentiation. In fact, maturation of adipocytes is a very distinct response pattern in MLS. From histology series, we have seen that radiation induces a large reduction of tumor cells, increased hyalinization and adipocytic maturation and necrosis, and also a decrease in inflammatory cells. A relatively recent histological study showed clearly that the histological response to radiotherapy is an early event. In fact, even after a modest dose of radiation, there are changes during the first 8 fractions, with the maximum response after 16 fractions, which is very, very early. And that shows the great radiosensitivity of the myxoid liposarcoma. The following, please. The radiosensitivity of liposarcoma is also confirmed in some small clinical series where following preoperative radiotherapy, we have seen a significant reduction in the volume of residual viable tumor, which is much, much lower compared to other sarcomas. And also, we have seen a significant decrease in the tumor volume compared to other sarcomas. We have very good local control following surgery and radiotherapy in a significant proportion of patients with MLS. Also, we have very few local recurrences and an excellent 5-year local recurrence-free survival. Recently, we have tried to decrease the dose of preoperative radiotherapy and see if that has an effect. That was the DOREMI trial, which was published in a preliminary form and showed that even that this reduction from 50 gray to 36 gray results in excellent local control. Also, more recently, there has been a good attempt from Poland where patients with myxoid liposarcoma were treated with hypofractionation, 5 fractions of 5 gray preoperative radiotherapy. And in fact, they have shown almost 60% response rate and 100% of local control. The following, please. Radiotherapy has been used for palliation for patients with metastatic sarcoma for long. In fact, we always believed that sarcomas are very radioresistant, and we didn't do much. During the past decade, we have new, very advanced radiotherapy techniques like stereotactic body radiotherapy, which have been used to treat several tumors in several parts of the body, and also we have used them to treat metastases from various types of sarcomas. This is a very elegant technique which uses rigid fixation, advanced image guidance, complex treatment planning and delivery systems, and results in a highly conformal dose distribution around the tumor. That means that the dose around critical areas is much reduced, and therefore toxicity is much lower. Each fraction of stereotactic radiotherapy delivers much higher doses of radiation and increase the biological effectiveness. For sarcomas, which have a very low alpha-beta ratio, the use of fewer larger fractions results in better responses. SBRT is a non-invasive treatment with minimal morbidity and could be offered basically to all patients who are not surgical candidates for metastasectomy, and also can be offered to all sites of disease, everywhere in the body. Next, please.
Στρίψτε αριστερά. Στη συνέχεια, στρίψτε δεξιά.
There is good evidence that
Doctor,
Please unmute.
please unmute your
Mute.
microphone, Dr. Vini, please.
There is good evidence that SBRT offers excellent local control rates and potentially improved overall survival, has a good tolerability. There may be a delay in starting systemic therapy and probably early prevention of tumor-related complications with avoidance of emergency or salvage surgery. Next, please. There are some small series, retrospective mainly, and only one prospective study with small numbers of patients treated with SBRT for lung metastasis from soft tissue sarcomas. Among those, there are small numbers of myxoid liposarcomas. From all these series, we can see very high efficacy, very good, excellent local control, very favorable toxicity profile, and on assessing all these studies, we can see that the most important prognostic factors for SBRT efficacy are age. Basically, younger patients respond better, the grade of the sarcoma, the number of metastases, and the time interval from the initial presentation. Next, please. Just a few years ago, the group from Rizzoli published an overview comparing SBRT versus metastasectomy in patients with pulmonary metastasis from soft tissue sarcoma. They analyzed 15 surgical series with over 1,000 patients treated with metastasectomy and 6 SBRT series, more recent, with almost 200 patients. Of course, the limitations are many, and what they have seen is that the cumulative mean overall survival time was basically similar in both of these groups. We cannot say much based only on this overview, but just only that local treatment of lung metastasis from sarcomas with SBRT seems to be a suitable alternative to metastasectomy in selected patients. But, of course, prospective randomized trials are necessary to draw final conclusions. Next, please. As I mentioned earlier, lots of limitations exist regarding the role of SBRT. The most important is the lack of convincing scientific evidence. We don't have any prospective studies. We have only very small retrospective series. The only available single-arm prospective clinical study showed excellent local control with minimal toxicity. In all these series, the fractionation differed significantly. However, we do know quite a lot from treating with SBRT other types of tumors, and we know that the fractionation regimen should be individualized, considering many factors as the predicted radiosensitivity, the site of the disease, the previous radiation, concomitant systemic treatment, and of course, performance stages. Another important issue regarding the role of SBRT is the late toxicity. All these series have very short follow-up at present. We need to know more. We need to have longer follow-ups in order to know the toxicity of those very large doses. And for this reason, data collected in prospective registries are very important. Next, please. However, despite all this limited evidence, SBRT is a viable method of treating oligometastatic and oligoprogressive disease from soft tissue sarcomas. It has a good efficacy, favorable toxicity profile, is widely available, and it's a good alternative to more invasive surgical approaches for several patients. Data regarding the role of SBRT in rare diseases should be collected in prospective registries, and in fact, the ongoing international project, the OligoRare, may answer these unsolved questions regarding the true benefit of SBRT. Next, please. Another issue is the concurrent or concomitant use of systemic therapy together with SBRT. We know that systemic therapies, in addition to contribute to obtain systemic disease control, can increase the effects of radiotherapy acting as radiosensitizers. The mechanisms can be several, like induction of DNA damage or interaction with relevant cell processes or modulation of cell cycle. The combination of trabectedin and local radiotherapy, which was not SBRT, it was a palliative 3D conformal radiotherapy, has been proven to be safe with no additional toxicity and with very interesting activity. And at present, there is an ongoing study investigating the combination of trabectedin and SBRT for lung metastasis from soft tissue sarcomas. And the final, please. So in conclusion, patients with advanced sarcoma, either recurrent or oligometastatic disease, should be managed by a multidisciplinary team in an individual basis, aiming to provide the best outcome with the best quality of life, always respecting patient preferences. Many patients with advanced sarcoma could benefit from local therapies. New radiotherapy techniques, such as stereotactic body radiotherapy, are able to achieve local disease control in selected patients with metastatic sarcoma and can be an alternative to metastasectomy in patients not suitable for surgery. Systemic drugs combined with radiotherapy could be also used to increase the effect and improve overall response and outcome. Thank you very much. And I'm really sorry for all this trouble. Thank you.
Thank you very much, Dr. Vini, for your presentation.
Thank you, Luisa. I think we managed
Yes, but
have your presentation.
Proceed now to the case.
Professor Papachristou, I think we need to start with the cases.
So I would like to ask Dr. Ivy Dr. John to start presenting the cases, and then we'll have after the presentations a new discussion. But I mean, we're a little bit out of time, but I think we'll manage to be in a reasonable time. So Dr. John, please.
You should be able to see my screen.
Yes.
Correct? Yeah, perfect. So I'll do two cases. I'll go quickly in the benefit of time. So this is a 48-year-old male with a 12-centimeter deep-seated right thigh mass. It was core needle biopsied. This is what the biopsy showed. So it is a mature adventitic proliferation. We don't see significant cytologic atypia, and we see a fair amount of foamy histiocytes over here. So since it was 12 centimeters above the cutoff of 10 and it was deep-seated, the specimen was submitted for MDM2 FISH studies, and it was negative for amplification. And this was signed out as a lipoma with fat necrosis. Subsequently, the specimen was excised and it shows similar findings to that of the corneal biopsy. But in addition to this, it also shows areas that look like this. So now we're seeing lipoblast, right? So you're seeing univacculated as well as multivacculated lipoblast, some hibernoma-like areas as well, with some amount of necrosis. And when we sampled the specimen more thoroughly, now we're starting to see what looks like a myxoid liposarcoma with those prominent chicken wire vascular pattern, as well as these spindle to ovoid cells in a myxoid background. And then we're seeing more characteristic areas of what looks like a myxoid liposarcoma. Subsequently, DDIT3, or previously known as CHOP FISH studies were performed. This was positive for gene rearrangement. So the diagnosis is on the resection specimen is a differentiating myxoid liposarcoma with a component of mature fat. So this is fairly rare. I've probably seen it twice in the last decade. And the pitfall is that they can mimic lipoma with myxoid change. And moving on to case 2, it was an 80-year-old male with a 10-centimeter mass involving the right groin. The patient had a prior history of prostatic adenocarcinoma, status post-radiation, status post-prostatectomy in 2008, and subsequent radiation to the prostatic fossa in 2010. You can see this is a 10-centimeter mass involving the subcutaneous tissue of the right groin. So we think about common things first. We think about, oh, is this a possible of metastatic prostatic adenocarcinoma versus some sort of radiation-associated sarcoma in this context. So on the corneal biopsy, we have a cellular proliferation of sheets and nests of epithelioid cells. Closer examination, you can see that these cells have an epithelioid morphology with a vesicular nuclei, prominent nucleoli, and amphiphilic cytoplasm. And there's also a prominent inflammatory, in this particular case, intermixed with neutrophils, fair amount of neutrophils. A portion of the tumor showed a more spindled morphology. So we did some immunostains, and the lesional cells were positive for Desmond and SMA. So if you saw something that looks like this in the abdominal cavity, you would think about epithelioid inflammatory fibroblastic sarcoma. But outside the abdominal cavity, it's hard to think about that diagnosis. Regardless, because of the morphology and Desmond and SMA expression, we performed an ALK immunohistochemical stain, which showed nuclear membranous staining with ALK1 immunohistochemistry. Subsequently, the specimen was submitted for the fusion panel, and it detected a RAN-BP2 ALK gene rearrangement. So the diagnosis is an epithelioid inflammatory myofibroblastic sarcoma. So this is actually the first case to be reported outside the ventral cavity. So I had my fellow report it. And sometimes it's good to think outside the box and not really put different entities in certain locations only. Those are my 2 cases.
So, thank you so much for the cases. They're very interesting, and actually they show us how sometimes molecular analysis helps us. And I think that in the last case, the treatment may have changed. I mean, I would like to know the oncologist point of view as regards this finding here, and how this finding changes the treatment plan of these patients.
Yeah, I think it's certainly very interesting. You know, it's been diagnosed as IMT or inflammatory myofibroblastic sarcoma of the ALK translocation. Certainly, we have good agents now that we can consider using, such as crizotinib, which has been shown in the clinical trial, as well as approved, I think, in various jurisdictions to be used in this particular type of tumor. And there are also other ongoing trials of other ALK inhibitors. As you know, aside from crizotinib, which is a first-generation ALK inhibitor, we have second generation with third generation as well. So certainly those, I think, trials are ongoing, but this actually does open up a treatment option for potential patients.
That's interesting. And another question is, how often do you do NGS in sarcomas? I mean, is it a routine procedure, or you strictly select cases that really need to have this molecular analysis, or oncologists ask you to more and more to do more NGS analysis in the case that you have? I mean, this is an issue that also happens here in Europe.
So it's a mix of both. Sometimes it is oncologist driven, and a lot of times it's based on the morphology. And usually with fusion-associated tumors, you can kind of predict it based on morphology because it's often sort of bland looking, has a monomorphous or sort of uniform cytomorphology. And so those are the ones that we actively select for NGS fusion panel.
So your oncologist also agree with that. So if you say to him that, or to her that, of course, these findings, and we believe that it's not a fusion-driven tumor, and you say there's no need for NGS, do you follow your advice, or sometimes they say, okay, maybe we'll see, maybe something we'll find to help us cure the patient?
I mean, academically, there is a bit of an interest nowadays because we're increasingly finding fusion-associated tumors and that are reportable and things like that. From an academic standpoint, it is interesting to run NGS fusion panel. But a lot of times, if it's like a slam dunk myxofibrosarcoma or pleomorphic liposarcoma, I'll say that it's not required.
I think that we should proceed with the next case because we're running now on extra time.
Yes, George, you're right. So, Dr. Long, could you please present your cases?
Oh, I didn't know we had to present cases.
Oh, okay.
Sorry.
No worries, no worries, no worries.
No worries.
Maybe it was good because we're running out of time, but anyways.
So, Dr. Gikas maybe has something to present, or?
Well, I kind of presented my two cases as part of my presentation, so I'm happy with that. I don't know if Dr. Vini, I was trying to find in my file here a nice case of myxofibrosarcoma. So I don't know if Dr. Vini wants to go ahead first, and whilst presenting, I will prepare a quick case for you.
Sorry, I have presented already my
I
case.
agree. Dr. Vini also based her presentation case, so it's already.
The presentation of Dr. Vini was in the form of case presentation.
Yeah, so it was
We're done.
much of the case presentation issues. I don't know if there are any questions from the panel or from the audience. Or...
No. It seems we are okay and we are on time.
Yes.
Finally, yes.
That's good. So thank you very much for being with us, the speakers from the United States, and Dr. Long and Dr. Gikas and Dr. Ivy and Dr. Vini. Thank you so much for being with us. It was a good course. I mean, maybe around 50 people watched our webinar, which is quite a good audience for such a restricted tumors in Greece. So we're proud of that. And of course, the presenters helped this and were very good, so the audience was challenged and stayed with us. So I would like to say goodbye to you and for our Greek friends. On Saturday, we have our event in Mount Helmos. The Hellenic Society group of sarcomas and tumors will have a small round of events there. So we would like you to be there and help our effort to support and to make our group be more visible and to make people know about sarcomas, which are so rare. So in Greece, we need to provide all the information to these people. So this kind of events help us. So please be there. And also, of course, the masterclass that we have, just like you, Dr. Long, it will be in December. So it will also be, I mean, both virtual and in real presence. So we'll be more than happy. Dr. John as well, we'll send you the link. So if your time helps, more than happy to be there and watch this very interesting masterclass. Actually, we have, it's the 7th, I think, masterclass, isn't it right?
Eighth
Masterclass. So it's very well organized. Speakers are very good. So we're more happy to have you there. So,
and
absolutely.
Before closing, our next webinar, which is going to be about childhood sarcomas, will be on the 2nd of October. We will send you the links. It is going to be mainly with pediatric oncologists, and we will be happy to see you there too.
So with this, we'd like to close. Thank you so much again, and looking forward to seeing you again in next webinars or meetings.
Thank you very much.
Thank you so much.
Thank you very much. Thank you very
Thank
much.
you.
Bye.
Goodbye.